All right, let's go ahead and get started. First, I just want to give an overview of our Prevention Research Center for those of you who might be new to our webinar series. Prevention Research Centers are a network of CDC-funded academic research facilities in the US that study how people and their communities can avoid or counter the risks for chronic illnesses. And our Prevention Research Center at Georgia State, that's headquartered on the Clarkston campus at Perimeter College, works with community organizations, state and local governments, residents, and other partners in Clarkston, Georgia, to develop, implement, and evaluate culturally and linguistically responsive interventions to address disparities and determinants of health for migrants and refugees, and then to disseminate that work at the community, state, and national level. Today, I'm very pleased to welcome Dr. Mary Bunn. She is an assistant professor at the University of Illinois, Chicago in the Department of Psychiatry. She's a core faculty member and a co-director of the Global Mental Health Research and Training Program, and also a clinical faculty member in the Mood and Anxiety Disorder Program, where she provides therapy services to survivors of war, torture, and forced migration. Her research program focuses on community-based mental health prevention and care interventions for refugees and forced migrant communities across the migration continuum. So this involves bridging prevention and intervention research to integrate a spectrum of services that are used for communities with diverse needs. She's particularly interested in peer service delivery models, therapeutic processes, and how to best mobilize social and family resources through interventions to enhance coping and well-being. And today she's going to talk to us about leveraging implementation science and design methods to develop community-based mental health services for refugee families and communities. So welcome, Dr. Bunn. I'll go ahead and stop sharing so you can share. We're really pleased to have you with us today.
Thank you so much for that wonderful introduction, and thank you to you and the Prevention Research Center and Georgia State University for inviting me to talk today about some of the work we're doing in community-based mental health. As I mentioned to you, this is really the first public presentation that I'm giving about this project that we've been immersed in for the last several years. So it's very exciting to have a chance to share it with the broader community. So just give me a moment while I share my screen here. Okay. As you heard, I'm going to talk today about kind of leveraging and blending some of the methodologies from implementation science, particularly thinking about adaptation methods and implementation science, and then human-centered design methods to adapt and test community-based mental health services for forcibly displaced communities. This is really just to provide a little bit more of a context for who I am. I'm a trained licensed clinical social worker and have been working with refugee and forcibly displaced communities across the migration continuum really for the last 20 years. And it's only in the last more recent period of my career that I've shifted into a research role as well. So this is an area that has really, defined my professional trajectory, and an area that I feel very passionate about. I'm going to really principally today talk about work that I'm completing as part of a National Institute of Mental Health funded K01 study, and which involves working with refugee families from Arabic-speaking countries in the Middle East, working with them here in Chicago, which is where I am, to adapt and then test a family-based mental health intervention. And just, what you see here are photos actually from our adaptation process and some of our co-design team members and partners who you'll learn about more over the course of today's presentation. So just to orient you to my plan for today, I'm going to discuss the background research that really led to this K01 award, and then spend a good amount of time talking about our adaptation methodology, process and findings, and the development and articulation of this new what we call CAFES 2 model, which is a family and social strengthening group intervention. And then hopefully, if all goes well, we'll have time to hear from you, hear your questions, hear your comments. I want to start by introducing my colleagues, my team at UIC, which are all part of the lab I run, which we call the Flourish Lab. And so all of these individuals, share, can celebrate in today's presentation and have been, remarkable partners in this work. I want to start by just setting the context for our discussion today, and start by saying that really in the mental health field for refugee communities or forcibly displaced communities, much of the focus historically has really been on investigating the ways that experiences of war and forced displacement and resettlement impact individuals, and particularly negatively impact mental health. And this is, of course, a critically important area of concern. But my work in this area, my research, is also really principally focused on how these experiences impact families and also social systems of care and connection. And so what you see here is just summarize some of what we know from the existing research in this area, which is naturally the impact of traumatic events and displacement on family relationships that can lead to family conflict, parenting difficulties, intergenerational conflict, and poor mental health in caregivers and children alike. And we also know that war and forced displacement also leads to systematic disruptions in social connections and interpersonal connections of support, right? We think about family separation, losses to community relationship, and the support that is embedded in those relationships. So that's sort of on the vulnerability side. And then thinking, from a strengths and resilience point of view, at the same time, it's really important to recognize the critically important role that family relationships and social relationships play in coping, adapting, and making meaning of adverse life experiences. And thus, these are really critical resources that need to be preserved or strengthened for individuals and families who are displaced. So this really, I think, elevates the need for further development and testing of family-based mental health models that not only attend to mental health needs, but which really principally aim to strengthen family relationships and also supportive social networks that are critical to family health and well-being. So today I'm going to be talking about, as I said, this NIMH-funded K01 study and the work that we've completed to date to adapt a multiple family group intervention called CAFES, which stands for Coffee and Family Education and Support, and adapt it for use with refugee families from Arabic-speaking countries in the Middle East, and also adapt it for delivery by peer providers. So people who we see as having shared cultural and linguistic background and life histories as intervention recipients. And then the latter part of my talk today, I'll share with you our upcoming plans to test the model in partnership with public libraries. Let's see. Before I go on, I just want to say that in addition to the Flourish Lab team members who I mentioned, I want to say that this project is being conducted in close collaboration with refugee families and several partners, including the Syrian Community Network, ICNA Relief, the Skokie Public Library, and the Edgewater branch of the Chicago Public Library. So looking here, this gives you a sense of the overall study design. And this study is multi-phase and uses what we call a hybrid type 1 implementation effectiveness randomized pilot trial design. For those who may not be familiar, hybrid research designs are trial designs that take a focus both on looking at the effectiveness of the implementation strategy and also explicitly collecting data on implementation process. and outcomes to facilitate subsequent implementation efforts. And in this study, we're using an implementation framework called EPIS, which is both what they call a process and determinants model that's really well suited to our study because it helps us to identify both barriers and facilitators, but also guides us all the way through from start to finish, from the exploration phase all the way down to even a future stage of really testing effectiveness more robustly. So today I'm going to hope to review findings from the formative research that we've conducted, which really laid the groundwork for this KO1 study, discuss our adaptation approach and findings and early testing of prototypes in preparation for our upcoming pilot trial. So just very briefly, there's several conceptual frameworks that are informing the development of this project. The first is a prevention framework, which really aims to reduce the incidence and prevalence of mental health problems by targeting risk factors for refugee families and also strengthening protective mechanisms. The model you see here is actually taken from a framework that's used in global mental health settings or humanitarian emergency settings called the IASC framework or the Interagency Standing Committee framework that just maps out a cascading system of stepped care, starting with basic services, then to more mental health promotion, prevention, and finally at the upper end of the pyramid, more specialized clinical services. And just again to say that in this field of care of refugee mental health, we've seen heavy investment in terms of research at the upper end of the pyramid, and really a need to delineate models that can be delivered earlier on. We know that individuals and families come with elevated risks of mental health, so why wait until they escalate and become severe? There's opportunities to intervene earlier on in the system. Also, just in terms of how we think about the development of mental health, and we think about well-being overall, thinking about a multi-system ecological framework that really attends to the numerous interrelated individual, family, social, and structural factors that impact health and well-being. And I know that that's something that the Prevention Research Center is thinking a lot about, bringing a social determinants framework to your work. And then also thinking about some both family and community resilience as three theoretical frameworks informing our research project, with family resilience really identifying family protective processes that can reduce the negative consequences of hardships, and community resilience thinking about social capital, physical infrastructure, and these culturally embedded patterns of interdependence that can also be very useful in terms of overcoming adversity. Our formative research for this NIMH project began several years ago and really began with partners here in Chicago with this overarching aim of helping refugee families thrive. And we conducted individual interviews with caregivers. We conducted individual and small group interviews with focus groups with youth, and engaged in a consultation process with key stakeholders and service providers. Again, we were principally focused on refugee families from Arabic-speaking countries. So I want to share a bit what we learned from that formative research and how that led to where we are today. So firstly, we asked both youth and caregivers about, their life experiences, their needs, problems, strengths, and help-seeking preferences. So in terms of needs and problems, not surprisingly, we found multi-level needs and problems, starting at the most basic level in terms of housing, jobs, discrimination. But again, thinking of that previous pyramid, also thinking about a number of social and community level vulnerabilities like loss of social support networks, for youth, especially bullying and challenges with peer relationships. At the family level, certainly separation from family members, changes in family roles, parent-child dynamics related to adjusting to novel cultural contexts, And then, of course, at the individual level, a range of mental health and psychosocial concerns. We also, examined what are the ways in which families cope and adapt to circumstances and resettlement. And we devised a process model that you see here, which depicted interactions between these diverse contextual vulnerabilities and adverse social drivers like exposure to past violence, but also English language challenges, housing, employment, stigma related issues. And then looking at multi-level coping and adaptation. So we identified, for example, drawing on faith as an important individual level coping process, communication patterns related to communicating openly within family, and then social strategies related to having a few close friends, and that those were coping and adaptation process that really promoted mental health and well-being, both in terms of emotional distress, but also appeared to promote family closeness and family functioning, and also enabled a broader sense of belonging and access to support in their new home communities. Finally, we also look specifically at mothers' experiences in resettlement and the process of mothering, both looking at caregiver stress and also, again, thinking about adjustment among Syrian and Iraqi refugee women. And we found that mothers in particular, found that they were really bearing a large burden in terms of support and care for their children, and they were trying to devise responsive parenting practices that could ameliorate some of the diverse challenges that their children were facing. And we found that this process had both led to a sense of accumulating maternal burden and exhaustion, while at the same time also reaffirming their maternal role and identity. Finally, in terms of help-seeking preferences, we learned about some of the implementation determinants in terms of models that were preferable to families, what they were looking for in terms of help-seeking. And so you see here kind of three main themes. One is groups of families, this idea that families would benefit from coming together in a group to meet each other and share experiences. Families also identified a preference for what we came to identify as peer-led services. So they talked about sharing experiences with others, going through similar life experiences could really be helpful in terms of alleviating difficulties, reducing isolation, and promoting social support and problem solving. And then this idea of the timing of services. So earlier in resettlement, in the first few years of care, what we heard from families is that there's often a very robust response when people first arrived in terms of being engaged with resettlement organizations. But then often access to formal support kind of drops off after an initial period, and families emphasize the need for more prolonged access to support and services in those first few years of resettlement when there's many challenges and when support and care would be most useful. We also, as part of our formative work, conducted a systematic review of family-based mental health interventions for refugees, both in resettlement context, but also in humanitarian contexts. And essentially what we found is that only 8 eligible studies that met our very broad inclusion criteria. We looked at pre-post designs, quasi-experimental. We really tried to be as inclusive as possible to capture the literature as best we could. Nearly all of these studies were what we might characterize as prevention-oriented interventions. And I think the findings overall really emphasize the nascent state of the literature in this area, and the need for much further development and robust testing of family-based mental health models. We did we did kind of conduct a analysis of the different types of family-based mental health models that we were able to identify, and we identified 3 main types: parenting interventions, which were the most common of all, multiple family group interventions, and then home visiting interventions. And so you see here that these interventions have been tested with different culturally diverse groups of refugee communities. And at the bottom, you see also some of the exemplar components that are included in these different models. Just to say, we also, conducted a distillation of the common elements across all different intervention types, and we actually found an incredible amount of similarity in terms of the core components, whether it was parenting, multiple family group, or home visiting, which I think is an interesting finding, worthy of further investigation. I particularly had an interest in this idea that families identified around a group intervention. And this was informed by my own earlier research in this area of group interventions for trauma survivors, which really highlighted their particular and their unique potential in terms of strengthening social connections. And then specific to Syrian refugees from work I conducted on a group intervention in Jordan, which identified relationships within groups as really the key active ingredient, which contributed to diverse mental health and psychosocial benefits. So, ultimately, ultimately, we selected this intervention called a multiple family group intervention, which brings together family members from multiple different families who are experiencing similar culturally mediated family stressors. Typically, they involve families who have at least one family member who's experiencing some degree of mental health distress, so more of a selected prevention intervention. And to date, these interventions have been delivered in community and school settings, and some of the common intervention components include interfamilial discussion of stressors affecting family relationships, development of strategies and coping to improve family functioning, and identification of family strengths and cultivating a family narrative. So we particularly ultimately selected cafes, coffee and family education and support, because we found that it had, prior to selecting cafes, I'll say we looked across the literature. I just told you about the review of family-based mental health interventions, but we also looked at group-based, peer-led to sort of see what would be a viable choice for our research. But we found strong synergies between the cafes model, both in terms of being prevention-oriented, having this family-level focus, and was a group format, and had utilized non-specialist providers from the same community. And really, it was the only intervention that had been tested in a large-scale effectiveness trial at the time of our review. So we selected this as a base model that we could adapt to meet the needs, we thought, to meet the needs of refugee families from the Middle East. We did, following all of this formative research, we conducted an initial adaptation of the intervention based on what we learned. And you see at the top what's circled. Those are areas that we knew we would need to add new components. We would retain the cafe, that sort of middle level captures the cafe's intervention. And we knew we would need to add new components to really promote self-management and emotion regulation, which came through clearly in our formative work. And then we really wanted to think about opportunities to really leverage that group setting to better promote social connections and support. So within implementation science, as I'm sure many of you already know, adaptation is a subfield that's really concerned with this process of thoughtful and deliberate alteration to the design or delivery of an intervention with the goal of improving its fit, effectiveness in a given context. And just as there are numerous implementation science frameworks, there's also numerous adaptation frameworks, which share many commonalities across them. Most follow this kind of stepwise fashion that focuses first on identifying needs and relevant interventions, and then adapting to new contexts and populations. And then following this, there's several additional steps for adaptations, developing the new intervention model, and then importantly, pilot testing the intervention. In this study specifically, we were looking to draw upon the adapted framework as our implementation adaptation science framework. But then we were also really, we were also really aiming to integrate human-centered design into the adaptation process, with the goal of further enhancing the process and the fit for new populations, delivery agents, and contexts. So Dr. Erin Lyons is somebody who's writing a lot about human-centered design, particularly in terms of mental health interventions. And he describes human-centered design as a process that reflects a set of methods that involve the development of products, technologies, other artifacts for direct human use. And human-centered design is really characterized by the requirement that the human perspective is considered essential to the conception and eventual design of these products that people will use or be affected by. Human-centered redesign of mental health and psychosocial interventions in general, and certainly for refugee communities, is a very new area, but one which we thought could provide an innovative and really timely pathway for improving the mental health impact of some of these existing interventions. And as you see what you see here is represented the human-centered design process. And at the top, you'll notice this frame, observe, design, build, evaluate. And you'll see that it's very complementary actually with the adaptation approaches that are used in implementation science. We started to integrate human-centered design at the middle phase of what they called this double diamond. And at the point at which we had already identified an evidence-based practice in cafes, but we needed to open the aperture up again to consider changes and modifications that could improve the fit, the use, and the feasibility of the intervention. A subfield of design that we really relied heavily on in our process is called participatory design, which really collaboratively engages, consults, and develops solutions to problems as a mechanism to build the capacity of lay people and communities to develop or influence socially sustainable solutions responsive to their needs and aspirations. And participatory design does share elements with community-based participatory research, but it's not the same. And we thought this approach was especially essential in order to devise the intervention in ways that were culturally acceptable and suitable to the needs of community-based organizations and partners who would be implementing the intervention. So in our adaptation approach, we combined human-centered design practices and adaptation methods, drawing on the adapted framework to create an inclusive and a participatory adaptation process that address the needs of diverse end users, as they're called in human-centered design. So in the case of our intervention, that was families, those were peer providers, those were partners who would implement the program. And to accomplish this, we convened 2 co-design teams with diverse lived experience, and we really engaged them as co-creators of the adapted program. And what you see here is this 4-phase process of adaptation that we articulated to guide our adaptation work. Phase 1 really began with what we call participant engagement, where we were identifying members for our co-design teams. Then we moved into a concept exploration phase, which involved research activities that were really designed to solicit input into the multiple family group model itself, and suitability for families and for partners. Following this, we moved into a concept refinement stage, and this is where we really dove into the content of the intervention. itself to refine and improve components and also think about tools and homework assignments. In the third phase concept finalization, we really examined other elements of the program like recruitment efforts and delivery setting and peer qualifications. And then finally moved into a production phase in preparation for the pilot trial. And just to say that our co-design team members were engaged in all phases of this research. And we also conducted key informant interviews with youth, caregivers, service providers, clinicians over the course of this entire process as well. So we convened, I mentioned that we convened 2 co-design teams. We convened a family co-design team, which was comprised of dyads of caregivers and youth from of families who had arrived as refugees from Arabic-speaking countries in the Middle East. And then we also convened a partner co-design team that involved service providers from the community-based organizations who we were partnering with on the project. And I mentioned that was the Syrian Community Network and ICNA Relief. I do just want to say that we were, in applying for this grant, we were very intentional about focusing in on community-based organizations as our partners of choice. Because we see really when you think about the sort of service landscape, as I was saying earlier, available to newcomer communities, these community-based organizations, sometimes called mutual aid organizations, really provide vital service to resettling communities, but often are really not integrated in our efforts to develop evidence-based practices, and often don't see themselves actually as organizations that are delivering mental health care. But we really think that based on the often being staffed by people from the community and delivering essential services, that they had a really important role to play in terms of prevention-oriented mental health. So as we approach, I want to talk about our methods. How do we do this? As we approach the adaptation process and redesign process, we were thinking about existing frameworks like the one that's been developed by Stearman. But we were also thinking beyond that, like what might be the areas that we needed to attend to and be attentive to in our engagement with co-design team members and key informant interviews. So we thought certainly about the content of the intervention, but as I said, we also designed processes to get at outreach, recruitment, and engagement efforts, which we knew would be vitally important for success of the intervention. Thought about delivery agents, delivery setting and context, and also we're trying to think about long-term sustainability of the intervention right from the start. So to adapt the intervention and thinking of that 4-phase process, we used a number of different methods: participatory design, as I said, key informant interviews, observation, and secondary research. We conducted interviews, family interviews. We hosted co-design team workshops, interviews with community practitioners, process and artifact documentation. We conducted observations in the service settings where we were exploring implementation, and also conducted visual design research. I think one of the real unique attributes of human-centered design relative to adaptation of intervention is the creation of these design tools that you create across the process to really enhance the feedback that you're getting into the existing intervention. And so, we created a number of different tools consistent with those goals as I articulated in those 4-phase process, and which were intended to really generate meaningful insights from our co-design team members or key informants into the existing intervention. One of the rules of human-centered design, which I've come to learn and think is a great one, is that you never ask anybody to offer their opinion on something they haven't interacted with yet. And so you create, one of the terms in human-centered design are prototypes. So you create these kind of prototypes or design tools or artifacts as a way of giving people offering people a chance to have an interaction with what it is you're trying to develop and test. And the thought is that that gives you what they might call more higher fidelity feedback on those intervention elements. So we developed early on, for example, we developed a journey map that really mapped out the whole multiple family group model, and which enabled us to get feedback on challenges and opportunities. We conducted making activities. We had reflection exercises that we used with our co-design team members, that the goal was really to get them more into the headspace that they might need to be in, to better offer input into the questions that we were asking. We created detailed session overviews of the cafes model, developed skill cards, naming and identity brainstorming, et cetera. So this is just an example of some of the design tools that we used in our adaptation process. And also what we called intervention simulation. You know, the creation of that family co-design team was really essential because it allowed us to simulate the aspects of being together with other families, with both young people and adults. And co-design team members would often identify, for example, a challenge that they anticipated, like fathers aren't going to be able to come and participate in this group due to cultural norms. But then we would find ourselves in a mixed gender, multi-generational simulated group session where we could really kind of further probe around what that challenge might be and how we might problem solve around it. So ultimately, you know, all of these adaptation activities, we collected the data, analyzed the data, and led to a new model to move forward with. And the adaptation process resulted in what we call now the Cafes 2 model. That includes an initial home visit and 6 group sessions. And these, as I said, these co-design processes and data collection efforts guided modification of diverse program elements, which we thought would really better engage families, meet their needs, support implementation by peer providers, and really structure the program for a long-term sustainment. So I'm just going to review now some of the key domains of adaptation that came out of this process. And I'll try to be brief with this. First was this idea that focusing on family is really key. You know, overall, there was really broad enthusiasm for a family-based model that was very in line with cultural values of newcomer families from the Middle East, and that these models were rare in service organization, but were really needed. And through our data collection efforts, what co-design team members and key informants advised is to really even further strengthen families as a source of strength. So I just also want to orient you to this graphic. Those little dots mean that the finding has implications at multiple levels of the adaptation. So in the case of focusing on family is key, that influences everything from content to outreach to delivery agents to sustainment. And so now another critical finding was that outreach and recruitment was what was most important. And that influenced adaptations to content, but also to articulation of our outreach, recruitment, and engagement procedures. So, you know, talking about the need for a trusted individual was really going to be critical to build confidence and interest in the program. And an initial home visit was added to really support those outreach goals and gain full commitment. Another theme that came out of our adaptation was this idea of relentless engagement. And the idea is that, you know, stigma and certainly competing priorities and practical challenges that families face interfere with their participation. And so really embracing a strategy of consistent communication via phone, WhatsApp, was added to the adapted model to facilitate relationship building and really encourage ongoing participation. Some key areas for cultural adaptation pertain to participation of fathers, the mixed gender nature of the intervention, and also adapting for mental health stigma. So firstly, as I was just mentioning, norms and beliefs about father participation and bringing men and women together could really was identified as potentially posing a barrier to participation. And so we thought about family inclusive, non-stigmatizing, and strengths-based language and strategies. And we embrace those across all aspects of the program. Male and female peer providers are going to be hired to model and normalize mixed gender composition. But we've also really structured cafes to offer multiple entry points for father engagement that's not limited to their formal participation in the group sessions. And I'll talk a little bit more about that coming up. Another critical adaptation theme was to extend the benefits beyond the sessions. And so the idea is that families really needed a way to translate skills and experience of the group to their daily life. So we made a number of changes to help accomplish that. First was we created bilingual, visually compelling skill cards to support the use of new emotion regulation skills at home. We added a WhatsApp group to the intervention for participating families, and that's really designed to deliver program reminders, key messages, and create a context also for ongoing communication between families during and after the program. And we really thought about particularly the skill cards and some of these other activities that are meant to be brought home as drawing on this kind of transitional object concept, and that these program tools could really help evoke the positive experiences and attributes of the program long after it formally ended. Another key theme from the adaptation process is that family interaction by design. So content on parent-child relationships, family adversity, family identity was augmented to include more interactive activities that engage families together in the intervention in this creative storytelling process. And then we also created whole family homework assignments, which really extended the intervention opportunities to the home context and were really designed for all members to participate in them, regardless of their formal participation in the group sessions. In terms of peers came through the adaptation as an important concept, and this idea of trust and inspiration by experience. So there was strong endorsement for the peer model that could really inspire hope and trust as a result of navigating similar life experiences. But that would really require robust training and support structures to support skills and competencies and to promote self-care among peers, which was identified as a challenge. Finally, a theme of the adaptation was delivery in accessible community settings. So the program needed to be close to home, safe, accessible, and various community settings were identified through our research as potentially suitable, like libraries, parks, mosques, community centers. Ultimately, libraries were selected as our implementation setting, where connection to others in the new home community could be forged. And the idea is that embedding and co-locating the program in public libraries would also allow newcomer families to access the program while connecting them to other relevant resources. Okay, so this just gives you a little bit of a snapshot of what the Cafes 2 peer-led family and social strengthening intervention looks like. As I said, that starts with a home visit, and then the families participate in session 1. So this is part of the original journey map, actually, that we use to really articulate every step of the process and to solicit feedback into that. So families travel to the site, participate in the session, and then that process repeats 6 times. This is, far too much detail to get into, but this just gives you an overview of the Cafes program. Each session has an overarching theme, which you see represented here at the top: family strengths, family communication, parent-child relationship, family storytelling, family hopes and dreams, and families and communities. And then each session has three key pillars that match that early conceptual model I talked about. Coping with stress and emotions, strengthening families, and then also social relationships. And then you also see here some of the work outside the session, and then some of what's included in the WhatsApp group for each of the 6 sessions. This gives you what we call a placemat that tells you about some of the tools that we've developed as part of the CAFES 2 intervention, including the facilitator manual, the participant workbook, the skill cards, buttons. We spent time working with our co-design team members on designing a logo mark for the program, thinking about the tone, identity, and the feel that the program should have. And all of these things, this is where this kind of early prototyping comes into play in terms of human-centered design. So the idea is to not only engage co-design team members in this process of articulating the visual design, brand, and feel of the program, but then bringing them into interviews to test those with families and youth, and to gather feedback and refine and iterate. And over the course of our facilitators manual, all of the tools we think about readability, usability, which is where some of the strengths, I think, of human-centered design and those design methodologies really augment a traditional adaptation process. So just in conclusion here, some of the big takeaways from our adaptation process. First is just to say that this co-design approach, we really found it to be useful, dynamic, for adapting the family-based model. And as I said earlier, those design tools, the journey map, those reflection exercises, et cetera, those tools I think are really critical and often not included as part of a traditional adaptation process, but they really enable direct and structured interactions with various elements of the program and reveal challenges and design opportunities to strengthen feasibility and acceptability. I think another great benefit of this approach is that it really facilitated consistent integration of individuals with diverse lived experience throughout the adaptation life cycle, not only families, but service providers who would be ultimately implementing the program. I think from a process point of view, the approach really fostered this occurred over the course of a year. And so this really fostered a context of trust and honest reflection. And that I think really enhanced the discussion of necessary model adaptation changes. And the design decisions really emphasized usability and potential for long-term scale up right from the start. And then I think finally, this collaborative process really resulted in a shared sense of excitement, investment, and co-ownership in the program. And we're already feeling the benefits of that co-ownership as we're moving into our pilot preparation phase. Here you just see some quotes from our co-design team members. I really enjoyed this collaborative approach. Taking our time over the 6 months allowed us to develop our thoughts and carefully sculpt the program. The project moved at the speed of trust and care. And some other quotes from our team members that really illustrate their experience of the process. So we're currently now preparing for our pilot study. Peer providers are being selected from our partner organization, and they'll be trained to deliver the program in public libraries. 74 families will be recruited to participate in the pilot, 37 will receive CAFES 2, and 37 will receive enhanced control. And then we'll be really principally evaluating it for feasibility and acceptability and fidelity. But we'll also be preliminarily exploring the impact on mental health, family functioning outcomes, social support, and sense of community. I think I'm running out of time. This is best for another presentation altogether, but I do want to just briefly mention that relative part of this first AIM adaptation was also really robustly thinking through the peer role, how to first conceptualize the peer role within the context of refugee services, which may look different than peers in substance use or severe mental illness or other more well-established areas of peer support. And also to really define the core competencies that peers would need in order to be successful in this role. In global mental health setting, there's huge enthusiasm around what we call task sharing models, which uses non-specialists or peers to deliver evidence-based interventions, but historically hasn't been a ton of emphasis on what those providers need in order to successfully implement and sustain. So we wanted to be thoughtful about that. Ultimately, I'm going to skip over this so we don't lose our time for questions and discussion. But just conclude here by sharing the names of all of the individuals who share investment in this work and our partners. Grateful to our funders at National Institute of Mental Health, Syrian Community Network, ICNA Relief, Skokie Public Library, and the Chicago Public Library. And thank you. Hope we'll have time for a few questions and comments, and please contact me if you'd like to follow up.
Thank you so much, Dr. Bunn. That was fascinating. And I'm just so impressed by how methodical and careful you were in that adaptation process. I mean, that was a very heavy lift, and it shows. So thank you for sharing, taking us through that process. I learned a lot. Yes, so Sarah, I will answer a request for your contact information, Dr.
Sure.
Bunn, so we can definitely share that. A question about your willingness to share slides, so you can either comment on that now or later. And then a question, from Temple Moore, saying that you all know each other.
Yes.
And thank you for the presentation.
Oh, fantastic. Yeah, great to see a message from Temple. In terms of sharing the slides, some of this work is kind of yet to be published and such. So what we can do is perhaps work through a smaller condensed set of slides that I can share with you. But I think today's presentation has also been recorded, if I'm not mistaken.
Yes.
So yeah, that allows people a chance to revisit things. I know there was a lot to cover.
Indeed. So one question from Dr. Whitaker, who's part of our Prevention Research Center, is wondering what kind of supports you'll be providing your peer educators as they implement the program.
Yeah, great question. And this is, of course, the part of the presentation I didn't have much time to talk through. So we have, through this, one of the activities that we completed as part of our AIM-1 adaptation was we took a review of existing Medicaid policies and practices for peer services and behavioral health. We kind of systematically reviewed the literature on peer service models and work with refugees. We looked at existing competencies and we distilled a core set of core competencies sort of separate from the CAFES 2 intervention. And we've developed a training manual for those core competencies. So peers will receive an initial 40-hour training that includes training in those core competencies, as well as training in the CAFES 2 model. And we have developed a core competency scale to sort of assess the extent to which the peers have obtained sufficient proficiency, both in terms of core skills and CAFES prior to implementation of CAFES 2. But assuming that all looks okay, we're also taking a kind of developmental approach to the way we're working with peer providers. And so peers will receive 1 hour of weekly supervision. That'll be a combination of myself and members of the research team, and also a licensed clinical social worker who is not part of the research team. We'll be collecting data on not only fidelity to the intervention, but also observational data around implementation of CAFES 2, but also the extent to which those core competencies are being evidenced. We're running our pilot kind of in 3 cohorts. And so we run 2 sets of groups, and then there's a period of pause And during that time, peers will receive a refresher training before they implement the second cohort, another refresher training before the final third cohort. So we've tried to be really thoughtful about that area, knowing that peers will need support and thinking that peers bring so much to bear to this prevention-oriented intervention, and that also there are challenges associated with being a person with similar life experience, being potentially embedded within the community themselves. And so how to really best support and set this up for success. Thanks for that question.
Thank you. I'm just wondering about the challenges of having multiple families who don't know each other come together.
Right.
And just
you and everybody else, yeah.
and how like there's such an opportunity there
Right.
to meet other families with shared lived experience. And I have kind of a romantic notion myself of like being with other families that are like my family, right? Like we always kind of talk about building our village. And then in the reality, oftentimes families get together and they don't really care for each other, or they don't trust each other. And I know in a lot of our conversations in our community in Clarkston with people from a lot of different countries of origin, one common thing we hear a lot is that there's an attitude about not sharing what's going on inside the family with people outside the family, like that's none of other people's business. And so I just wonder how you're managing that.
How we're trying to navigate that.
Yes.
Absolutely. Yeah. And this is a question that comes up certainly. And we found that very same thing in some of our formative research, that people don't only have stigma about mental health, but about having personal problems of any kind. And that there's this real need to present your best face to the community. On the other side of that, what we know is that this model has been successfully implemented with other refugee communities. And we're really coming at this, we're being thoughtful about those issues and the content as we conceptualize this as a prevention-oriented intervention. So we are, our expectations about what gets shared and when, it is part of how we're thinking about that. So heavy emphasis is on family strengths and thinking about, what are your family strengths and how have you drawn upon those, and how could you even further solidify those? And I think also we've thought a lot about, taking a trauma-informed lens across the 6 sessions. So earlier on, we're being really thoughtful about what we're expecting people to share. And one way we've actually really navigated this is with how we approach breakouts within the group. So there's multiple times where we have breakout sessions, because it's not only about stigma and saving face between families, but also thinking about 2 generations. So in the early phases of the program, we keep family units kind of together during breakout activities. And when we come back together in a full group, it's more around debriefing around the process of the activity versus the content. But we also, particularly in terms of teaching skills for emotion regulation, do a lot of separation between youth and adults, knowing that, the way to go about promoting and teaching those skills may need to look different, and that youth might feel more comfortable working with each other. So I think using breakouts really strategically, we hope, is going to help overcome some of those. But I remember one of our co-design team members from our partner organization saying really early on, we have to be really careful about these issues that you're talking about, and yet people have to be vulnerable with each other, and we have to create opportunities for that, or this group will never work. And I think that was just such a insightful comment, and one I come back to But maybe you'll let me come back and I'll be able to report back about how some of these dynamics played out and how we negotiated them and how well that worked in the actual pilot trial.
We would love that. I think I can speak for all of us and say, yes, please do come back and tell us what you learn as you take the next step in the pilot process. This was so fascinating, and we appreciate learning from you today so much. And there's an additional question in the Q&A that I'm gonna send to you via email since we're a little bit over time.
Sure. Yeah, I'd like to answer that question.
But yes, let's get that. I'll get you all connected so we can get
Sounds
that
great. Sounds really
answered.
great.
And just want to give a little plug for our March Brown Bag. So we have Megha Shah, Dr. Shah from the Emory School of Medicine, who's going to be talking about leveraging primary care and social network resources to create a patient-centered approach to improve diabetes in immigrant communities.
Whoops, I cannot hear you anymore. Oh, there we go. Now I can. Thank you so much. Thanks. Bye-bye.